Hello and good afternoon. My name is Sandra Merritt. I'm the director of Club W, and I want to welcome you to today's presentation on varicose veins and the treatment of. Our presentation today is going to be presented by Vanessa Collins, who works for Midwestern Aortic and Vascular Institute. So I'm going to turn it over to Vanessa, and I'll let her tell you a little bit about herself before she starts her presentation. This video will be recorded and will be placed up on YouTube on North Kansas City Hospital's YouTube channel. Also, I will be emailing a link to this presentation so that you can view it at a later time as well. You will be offered an opportunity to ask questions via the chat box at the end, and we will get to as many questions as we can. Thank you and enjoy the presentation. Vanessa?
Thank you, Sandra. Again, my name is Vanessa Collins. I am a nurse practitioner here at Midwest Aortic and Vascular Institute. We have our main office is in North Kansas City. We also have an office in Independence and do some imaging in Liberty as well. So we have a great group of surgeons here. I am pretty passionate about venous insufficiency and varicose veins. So I'm excited to talk to you today. So thank you for the opportunity. I am originally from Nebraska. I moved here in 1997. My first degree was in psychology. I went into nursing after working in mental health for several years. I have my master's degree from UMKC. I've been working here at MAVI for almost 10 years, and I've been working in vascular surgery for about 15 years. So we'll get started here. Thank you again for the opportunity. So we're going to talk about chronic venous insufficiency today. But so just a little bit about vascular surgery. Vascular surgeons diagnose and treat a wide variety of vascular disorders, from complex aortic aneurysms to varicose veins. Some of the many conditions that they treat include abdominal aortic aneurysms, aortoiliac disease, carotid artery disease, peripheral artery disease, deep vein thrombosis, wound care. Lots of wounds are vascular related, so we do a lot of wound care. Lymphedema, mesenteric ischemia, which is the blood flow to your gut, peripheral aneurysms, dialysis access, thoracic outlet syndrome, and varicose veins. So with chronic venous insufficiency, it is quite a chronic problem. It's exciting for me to be able to help with the treatments because it affects so many people. It is an easy thing to treat, really, in an outpatient setting, is generally covered by insurance, and people really do get good relief. So chronic venous insufficiency is a common problem affecting women more often than men, usually in a 3-to-1 ratio. Causes varicose veins, which are those bulging, knotted veins that are most often in the legs that can be really painful and unsightly. Venous insufficiency is a medical condition, and the treatments are usually covered by health insurance. Varicose veins themselves are not spider veins, and they are not considered cosmetic. That's one of the common beliefs, is that really this is cosmetic, so insurance won't pay for it, but that's not true. Venous disease affects all ages, genders, and races. Risk factors for venous insufficiency include over the age of 40, again, affects women much more than men. Family history, this is definitely a hereditary problem. Prolonged standing or prolonged sitting, so we see this a lot in nurses and teachers, people who are on their feet for long periods of time, or people who just sit at a desk for long periods of time. Multiple pregnancies, heavy lifting, obesity, and smoking. Venous insufficiency can cause lots of symptoms in folks, and it's a little bit different for everybody. It includes aching, heaviness, burning, pain, fatigue, itching, nocturnal cramping, which is really nighttime cramping, restless legs, varicose and or spider veins, swelling, skin changes with discoloration, and venous stasis ulcers or wounds. These are some pictures here of some of the consequences of venous insufficiency. So on the left, you can see the varicose and spider veins. In the left leg here, you have more of these big, ropey, bulging varicose veins. And these here are more the spider veins that are actually in the skin surface. On the picture on the right, this is some of those chronic skin changes. This is lipodermatosclerosis, which is this kind of woody appearing skin in the lower leg. And this is a venous stasis ulcer. So over time, venous insufficiency can cause these skin changes. This what is called hemosiderin staining, which is deposits of the iron in the red blood cell that stain the skin. These ulcers can be really difficult to heal because the skin is not normal anymore. So just a little background with arteries versus veins in our general circulation. So arteries carry the oxygen-rich blood from our heart out to the rest of the body, to our organs, to our fingers, to our toes. The blood then drains into the veins, which recirculate the blood back to the heart, and the cycle begins again. So in this picture to the right here, the red is the arteries that take the oxygenated blood from the heart down to everywhere in the body. The light blue is the veins that are recirculating the blood back to the heart. So especially in the legs, the calf and thigh muscles actually work as a pump to push blood against gravity. There are one-way valves that are in our veins and our legs that are supposed to open and let blood recirculate back through to the heart that prevent blood from refluxing back towards our lower legs and feet. So this is just a little diagram of the actual anatomy of our veins. These two pictures over here really show that veins are really a network of just like spider webs underneath the skin. We have all kinds of deep veins, superficial veins. This picture over here on the left shows this bigger vein in towards the middle of the leg. That is our femoral vein, which is one of our deep veins. So the deep veins run in more towards the bone. They do 90% of the work, taking the blood back up to the heart. And those are the set of veins that we worry about blood clots or deep vein thrombosis. The saphenous veins, which are superficial veins, they do 10% of the work. This is the great saphenous here. They're the ones that generally, if they don't work properly, cause varicose veins and all the symptoms that go along with it. So this is just showing the deep veins, the superficial veins, and then if they're not working properly, result in the varicose veins and spider veins. Let me go back for a second here. The great saphenous vein is the one that starts right here in the groin and runs all the way down the inner thigh, down to the ankle. That tends to be the biggest problem vein causing varicose veins and all the symptoms that go along with it. Second biggest problem tends to be this one called the small saphenous vein that runs back from behind the knee down to the ankle along the calf. So the pathophysiology with venous insufficiency is it is a progressive and chronic condition. It is never an acute problem. It's not something that's generally treated on an inpatient hospitalization type setting because it is such a chronic problem. Venous disease develops when valves in the veins stop working properly and allow blood to reflux or go backwards and pool in the lower legs. So these pictures down here show this is a normal vein. Throughout our veins and our lower legs, we have one-way valves that are supposed to act like doors that open. And as those muscles push that blood back up to the heart, the blood should go up and then these valves should close so blood can't go the wrong direction and go back towards the feet. This one over here shows a diseased vein. So over time, the vein gets too big with all that blood pooling in the lower legs. The veins dilate, those valves don't meet anymore, they don't function properly. So as the body's trying to push blood back up towards the heart, it causes what we call reflux. The blood goes back down towards the feet and ankles, and it just complicates the problem. So venous reflux is most common in the superficial veins in the legs. That's the veins that do 10% of the work recirculating the blood. So varicose veins develop when the blood backs up from the refluxing valves in those veins. So these are not actually the saphenous veins that you can see. These are branches off of those saphenous veins that over time bulge. So pressure from the back of the blood causes the veins to bulge and appear ropey or twisted. Varicose veins can cause bleeding, changes in the skin color, and ulcers, like I talked about before. You can also get what's called superficial thrombophlebitis, which is actually pretty common with varicose veins. So the blood in these superficial veins, the varicose veins, can clot. And that is not a deep vein thrombosis. It's never life-threatening, but it can be painful. It makes those veins become hard, red, swollen, dilated, very tender. That just resolves with time. That's really best treated with heat packs, NSAIDs like ibuprofen or Aleve, and compression stockings. Spider veins are a little bit more of a cosmetic issue. So they develop in the skin surface where the blood vessels dilate, like you can see here. They're easily seen. They tend to appear in clusters that can look like a bruise. They usually develop from heredity, injury, like if you get hit by something like a ball, you can end up with spider veins, pregnancy or hormonal changes. Spider veins are usually not harmful, but they can be unsightly. Rarely spider veins can cause bleeding, especially we see them a lot in people's ankles, lower legs, and their feet. And because the blood tends to pool there, those can bleed. So to diagnose venous insufficiency, you do need to see a physician. They do a physical exam, they go over your symptoms, they look at your legs, they'll feel your veins. The diagnostic test that we do is called a vein mapping. It's actually an ultrasound that's done, again, in an office type setting. It's a non-invasive test in which an ultrasonographer uses the ultrasound technology to look at the veins in your legs to determine which valves are not working properly, how bad the problem is, and in which vein is affected. So when they do this vein mapping, they look at which way the blood is flowing. They can actually count how long blood is going the wrong direction. They can see which valves aren't working, and they actually measure the diameter of the veins. Over time, those veins become too big, they bulge. If the veins are refluxing significantly, so the blood going the wrong direction, treatment may be recommended to shut down or close those affected veins. Treatment options, there's multiple different options. Really, the initial one is just conservative management, which would be trying to manage the symptoms. One of the biggest things that helps with venous insufficiency and varicose veins is compression therapy, also elevation, because that takes gravity out of the picture, and exercise, because that helps keep those pumps, the leg muscles, working. I'll go over this a little bit on the next slide, but we usually recommend a 3-month trial of compression therapy prior to recommending any treatments for varicose veins. There are lots of different compression stockings out there, but a good therapeutic compression stocking is 20 to 30 millimeters per mercury. That's how tight the stocking is. Superficial venous insufficiency, like I said, generally affects the great saphenous and small saphenous veins. So there are different ways to actually surgically treat those veins. There is ablation, which that can be done multiple different ways. There is heat ablation, laser ablation, or different options for chemical ablation. And basically ablating the vein is sealing the problem vein off. The other option is vein stripping. Microphlebectomy is a procedure we do to actually remove varicose veins. Injection sclerotherapy treats varicose and or spider veins. A surface laser, similar to what they would use for like hair removal, can also be used to treat spider veins. For problems in the deep veins, which are the veins that do 90% of the work, the treatment is purely supportive, meaning treating the symptoms. You can't really surgically treat those because we need those veins. So really compression, elevation, exercise, weight loss. So with the compression therapy, most insurance companies will require a 3-month trial of conservative therapy with compression stockings before they will consider paying for treatments for these problems. Compression is what we call graded, meaning it's tighter in the ankle and then loosens up a bit as it goes up the leg. So it kind of helps push that blood back up. Knee-high compression stockings are usually adequate, and they can provide good relief of symptoms and help minimize swelling that we see with venous insufficiency. There are also compression wraps that we use a lot in wound care for people with wounds. A nurse or like a home health aide or a wound clinic would use those a lot. Ferro wraps, I'll go over a little bit in the next slide. And compression stockings of any sort don't need to be worn at night. When you are laying in bed or your feet are elevated, that takes gravity out of the picture, so you don't need to wear the compression. So these are just different types of compression stockings. So this one over here on the left, these are pretty traditional compression stockings. They're pretty trendy right now with a lot of runners. So there is so many options out there. These are joke stockings that you generally get from a durable medical equipment provider. You can also order them online. There are lots of options on Amazon. You can buy them in retail stores. These in the middle here are called ferro wraps. So this sock actually underneath is not tight. It's easy to pull on. These are really good for folks who have a hard time putting these kind of compression socks on. They're hard to get on and they're hard to get off. So folks with arthritis or even some breathing issues where they can't bend over and do that much exertion. So the sock slips on easily. This garment here slides on easily. And these are just separate Velcroed straps, really, so the patient can control the compression themselves. They just kind of tighten up the straps and it forms the compression. These are just a thigh-high compression stocking, but I really wanted to show you can do open-toed stockings. You just really need to include the foot. If you only have compression on the leg, it will tend to push swelling down onto the foot. Thigh-high compression stockings usually have some kind of a silicone band or silicone dots in this thigh band up here to help keep them up. So vein stripping is a procedure that's gone by the wayside quite a bit, actually. It's usually done in the operating room under under general anesthesia. It requires incisions like up in the groin where the vein starts and another in the lower leg. The surgeon actually has to tie off all those side branches coming off of that main vein, and they actually strip or remove that vein from the leg. It's pretty traumatic. Can cause lots of bruising, bleeding. It's not routinely done anymore for chronic venous insufficiency. It does require a longer recovery time and a hospitalization. So venous ablation is really what has taken place of the vein stripping. There are, like I said earlier, a lot of different types of venous ablation. There's laser, radiofrequency, and then there's chemical ablation. It's less invasive than vein stripping. It's usually done in an outpatient setting, like an outpatient surgery center, or we do it in our office. In that procedure, so once the, no, I think I'm gonna skip some slides here. Give me 1 second here. Oh, sorry. I apologize. So when the problem vein that was initially found by that ultrasound, that vein mapping, so the surgeon finds that vein with an ultrasound in the actual procedure. So if it's the saphenous vein, the great saphenous vein that runs along the inner thigh, they usually go in right below the knee. They numb a little area on the skin with some lidocaine. They take just a little needle and get down into that vein. Through that needle hole, they take a catheter and route it into the vein. Once that catheter is in place, they will, depending on the procedure, but generally inject numbing medicine all along the track of that vein. What it does is it helps the vein, it pushes the vein down around the catheter and helps push away the healthy tissue to protect it from the actual procedure. So with like a radiofrequency ablation or an endovenous laser ablation, once the leg is numb, the surgeon will turn the machine on. And as this is kind of showing that catheter in place, once the machine is turned on, they slowly withdraw that catheter out of the vein. It actually seals that vein off. It causes the vein to scar down and close all through that little needle hole down in the lower leg. So with endovenous laser ablation, then that's what this shows here. This little catheter tip here actually produces heat and it seals it off. Radiofrequency ablation uses little tiny electrodes to heat seal the vein closed. It works beautifully. Takes less than an hour to do a treatment like this. Venaseal ablation is another option for sealing off the vein that is more of what we consider a chemical ablation. So again, it's minimally invasive, done in the outpatient setting. Very similar start to the procedure. They access that vein in the lower leg under ultrasound. They numb up that little area. They get access into the vein. They put the catheter inside the vein. The nice thing about the Venaseal ablation or the chemical ablation is they usually don't have to do all those subsequent injections to numb up the leg. It's just that one access site. Then as they pull the catheter back out of the vein, they drop off a glue, and that glue actually hardens in the vein and causes it to scar down and close. And again, all done through a little poke hole in the skin. After we do any type of ablation, within the following days, we actually have a patient come back into our office and do an ultrasound to make sure the procedure worked and to make sure there's not any blood clots where we don't want them. So to treat the actual varicose veins, which are the bulging varicose veins that we see under the skin, The one procedure that I talked about earlier is called microphlebectomy. That is also done in the office, minimally invasive. Generally what we do is with the patient standing where those veins are big and bulgy, I take a Sharpie and we mark those with a Sharpie everywhere we can find one of those veins, because then once the patient lays down, they're not as obvious. So then we do numb up, we inject numbing medicine all along the track of the varicose veins. Once the patient is good and numb, we make a little hole right next to the varicose vein, either with a needle or a scalpel. In our office, I use just a needle hole. And then we have a tool called a vein hook that actually reaches underneath the skin, grabs the varicose vein and pulls it out through a hole. We grab that little vein with just some little clamps and pull it out. So you never get an entire long ropey vein out of one hole. So you'll have to periodically make other little poke holes to pull the veins out. But it gets the majority of those varicose veins out in one session. And it works really, really well with little to no scarring at all. Injection sclerotherapy can also treat varicose veins, but is also the treatment for spider veins. So injection sclerotherapy is actually injecting a medication. In our office, we use polydocanol. It can be used as a foam to treat bigger varicose veins. So if you treat the varicose veins with a foam, you would actually inject that in there. It causes those veins to kind of get hard, scar down, and then the body absorbs them with time. With spider veins, since those are in the skin surface here, you actually just inject into these little veins, and it does cause the vein to really break down and dissolve over time. Initially, the veins do look worse because the medicine actually causes inflammation in the vein, and then it scars down, and then as your body heals it, it either fades significantly or goes away. The thing with spider veins is it can take multiple treatments to get the veins to really go away. One treatment, though, you can get pretty significant improvement. So with venous insufficiency, there are all kinds of providers out there that treat varicose veins. So when you're trying to choose a provider, you just want to make sure that you consider the provider specialty and how closely it relates to venous disease and blood vessels, how long the provider has been treating the venous insufficiency, what treatment options are available, and do they accept your insurance? Because like I said, most of these procedures are covered by insurance. It's helpful to have a provider that will take care of all the pre-certification, all the insurance billing and all of that. The spider veins tend to be a little bit more on the cosmetic side, so insurance may not cover that, but they will cover the treatments for the ablation type surgeries, the varicose veins. So it really can provide significant symptom relief, and they're pretty easy procedures to go through, and folks get really quick relief from the symptoms that they're having. So again, I work for Midwest Aortic and Vascular Institute. This is our address and our phone number. We have two primary surgeons in our office that treat venous insufficiency, Dr. Wagner and Dr. Wilson. We have a dedicated vein care staff that do an excellent job. They are so good with the communication and scheduling. So let us know if you have any questions, any concerns. If you'd like any information, we can send you out anything. Any questions?
Vanessa, this is Sandra again, and in the chat, I do have a couple of questions. It
Okay.
says you mentioned spider veins can bleed. Do they actually bleed through the skin?
Yes, and they can bleed a lot. Patients that have had this happen will say it looked like somebody got murdered, that it just sprays everywhere. Because of the pressure from the venous insufficiency with the blood pooling in the lower legs, it causes a lot of pressure on those veins. That's why they bulge. So especially the little tiny spider veins, they'll get kind of like, looks like a purple bleb, like a little bubble in the skin. Happens a lot after people take showers, because when you're warm, the veins dilate and the skin gets softer. So it will literally shoot out of the leg.
That's interesting. So would you just recommend people like have dress it with just regular dressing?
So the most important thing to do if that happens is put the leg up and hold pressure right on it. So by elevating the leg, it minimizes the pressure from the blood, and putting direct pressure on there and wrapping it up. Sometimes people will have that once that happens, it will scab over, and then it will tend to want to, that scab will tend to want to break off and rebleed. So just keep it covered.
Very
If you
interesting.
can't get it to stop, you definitely need to go to the ER, but usually they will stop just with pressure and elevation.
Yeah. Another person asked, how long is the recovery period, and can you walk immediately after?
Excellent question. So depending on the procedure, yes, you can walk immediately afterwards. So the ablations, and especially more of the like the radiofrequency or endovenous ablations, we wrap your leg up from the toes all the way up to the groin with ACE wraps that you leave in place overnight. We want you up, a good combination of up walking and elevating the legs. So what we don't want right after those type of surgeries is any heavy cardiovascular activity, because that, when your heart rate is up and you're being really active, your veins dilate. So you want those vein walls to stay sealed shut. So we do want you up moving right away. We don't want any heavy cardiovascular activity. After an ablation, we usually recommend taking a couple days off of work, especially for people that are doing a lot of walking or working on their feet. For like injection sclerotherapy, there is really minimal restrictions after that. I still recommend folks not do any cardiovascular activity because they'll get better results, but we want you up moving right away.
Good.
So pretty easy recovery.
Well, good. So another question is, do spider veins turn into varicose veins? Have some that don't look like varicose veins, but do cause pain?
So spider veins don't turn into varicose veins. It's a little bit different beast altogether. So the the varicose veins are more like branches off of the saphenous veins, kind of that network of veins underneath there. So the spider veins are a little bit more in the skin surface. So the purple veins, and they can get pretty big. The spider veins can, but they'll never turn into varicose veins. And varicose veins don't really ever turn into spider veins either. They're different.
Okay,
You can definitely have both.
Yeah. Another question is, does your group, does MAVI accept Medicare?
Absolutely, yes.
Okay, good. And then another question is, do you have to wear compression socks for a period of time after an ablation?
Yes. Usually the surgeons here recommend you wear compression stockings for 4 weeks after the ablation. It really does help with the healing. It helps the whole, any of these procedures work better. It does help with any postoperative discomfort as well.
So another question is, and I kind of wondered this as well, the procedure, what kind of scarring is left after surgery where you loop the vein through the skin and have several loops?
Yeah, so that with the microphlebectomy, and in our practice, currently I'm the one that does all of the phlebectomies. I've just done it for a really long time and I enjoy it. And so I personally do it through an 18 gauge needle hole, which is a good size needle, but it's still a needle. A lot of people will use a scalpel. And so you can see, I have a friend that has lots of little tiny scars, and now she says it's way better than her varicose veins that she had because they were quite painful. So if someone uses a scalpel, you could have lots of little couple millimeter scars. The way I do it through a needle hole, and it's lots of little needle holes depending on how many varicose veins, but you may not have any scarring at all. And if anything, it might just be like a little polka dot, like a freckle.
Okay. And then another question, is there anything that you can do to prevent varicose veins and spider veins?
Compression stockings is the absolute best thing you can do. People who are on your feet for long periods of time, nurses, we always recommend wearing compression stockings because it can prevent it from happening. Heredity is such a huge factor that if it's just in your genes, it's probably going to happen no matter what. And for some folks, it happens even if they wear compression stockings all day, every day. So some people are just blessed with venous insufficiency and varicose veins, but compression is the best thing you can do to prevent or slow it down.
Here's another question. Do you recommend sleeping with your legs elevated?
If you have significant swelling, especially, yes. Now, if you're just having issues with varicose veins or for preventative measures, no, because when you, even with your laying flat, that takes gravity out of the picture. But getting the legs above the level of the heart, especially if you're dealing with swelling or bulging veins that are really uncomfortable, if you do elevate them, it will help. They actually make a big pillow that's angled, that is designed for venous insufficiency and swelling.
Okay, and then I do have another question in the chat box. Do spider veins and varicose veins come back after you've had treatment or surgery?
They can, yes, they can. So varicose veins, especially if you've had the ablation and we take out all the varicose veins, you are less likely to get more varicose veins back, but you can, especially if it's just one of those things that it's in your genes, and spider veins as well. So they're kind of a little bit different of a beast. They're a little harder to treat. So we can, get rid of all of them or significantly get them improved or reduced. But if you're on your feet, again, for long periods of time, you can get new veins over time, unfortunately.
Okay. Looks like there is, somebody's asking, will this be available online? And yes, we are recording this presentation and we will put it on North Kansas City Hospital's YouTube channel. So yes, it will be available.
What's really neat about venous insufficiency is I hear time and time again with patients after, especially even just after doing the ablation, that how much better their legs feel. We hear it all the time that I didn't know my legs were bothering me as bad as they were because it's so chronic. People get used to it. And they'll treat one leg and they'll think, I can't wait to get the other leg done because now I realize how much my legs were bothering me.
Mm-hmm. I've actually heard people say that their legs feel heavy.
Yes, I saw a patient the other day that said my legs feel like they weigh 100 pounds. And it's worse as you're on your feet throughout the day. I mean, you may feel great when your feet hit the floor out of bed, but that's because the swelling is down, gravity's taken out of the picture. But as you're up on your feet throughout the day, that's when the pressure starts to build up. And that's why you get the nighttime cramping and the restless legs, is because your muscles are having to work overtime all day long to help get that blood going back up in the right direction.
I don't see any more questions. So Vanessa, I want to thank you so much for this excellent presentation. It was very educational, and I think it will be a benefit to a lot of people. So again, thank you again for presenting this topic.
My pleasure, and absolutely anybody call the office because our vein team is excellent and happy to help with any questions that anybody has.
Okay, thank you. Thank you everyone for attending the presentation.
Thank you. Thank you, Sandra.
You're welcome. Bye now.
Bye-bye.